Well, hello, it's Bruce Williams again, coming to you from Bethesda, Maryland on another shelter-in-place Sunday. Well, don't have a lot going on here at the moment, so I thought I'd take some time and present Gross Path Challenge number 60. I hope you enjoy it. Now, last night was a night of sorts, celebratory here at the apartment. My son Connor turned 21, and that's a big day here in the United States. Here is Connor. He's a little bit dressed down for the birthday celebration, and you can see his sort of scraggly quarantine goatee that he is growing here, but he has his 21-year-old license. Here in the U.S., if you're less than 21, it's printed vertically, so getting this one that's printed horizontally is a big thing, which means you can go out and buy your own beer to celebrate the quarantine. Last night's beverage of choice was Corona beer, and here is a bottle of champagne, which we drank for his birthday. So happy 21st birthday, Connor. We are very proud of you. And he is not going into veterinary medicine. He wants to be a lawyer, and that's a good thing in case I ever get into trouble. Okay, slide number 1 is tissue from a horse. Can you give me a morphologic diagnosis and a cause? And make this a very carefully thought out morphologic diagnosis, because it's not as simple as you'd think. Okay, time's up. We are looking at the colon of a horse. There is a large area of infarction. It is a blanched area. Yesterday we looked at the venous infarct. We talked about mesenteric lipomas and how they make venous infarcts. And I said that those are generally very dark. And if you have an arterial infarct, it's very white because no blood actually gets to the tissue. And that's what's going on here. And if you looked very carefully, you can see that this artery right here, the wall is very thickened. There are multiple thrombi in it because it's been opened up. So this is cranial mesenteric. I'm not exactly sure. That could be a colonic artery, but mesenteric arterial thrombosis with arterial colonic infarction, or something along those lines, because I want your morphologic diagnosis to include this is a primary lesion, this is a secondary lesion. And this is a classic cause of colic, which is the result of infection by Strongylosis vulgaris. Remember that the 4th and 5th stage larvae of Strongylosis vulgaris are the ones that cause the arterial lesions. Often in the cranial mesenteric artery, you'll see formation of a pseudoaneurysm, an outpouching. The wall is very thick. There is a combination of granulomatous inflammation, eosinophilic inflammation, fibrosis, disordered smooth muscle proliferation. I'm going to call these proliferative and eosinophilic arteritises. And this is a 4th and 5th stage larva. The adults just live in the lumen of the colon. They don't do that much. They do suck a little blood, but that's about it. It's the larval forms that cause these arterial lesions, and this is a great large infarct in proximity to this damaged artery. Now, this infarction, you can see it in areas away from these arteries, and nobody knows exactly what the cause of that was. Was it these large clots breaking off and occluding arteries, or do the larval forms secrete some sort of vasoactive amine? Or some people even said, hey, there's such thickening here that's pressing on the nerves that innervate this section, and it causes the vessels to undergo vasospasm. I don't know so much about this, so we have a focally extensive proliferative and granulomatous or eosinophilic arteritis with arterial colonic infarction, Strongylosis vulgaris. Now that most people use ivermectin, this is a pretty uncommon lesion, but back in the days before ivermectin, we saw this. It was probably the most common form or reason for colic back in the day. Slide number 2 is tissue from a calf. Or I should say tissue is a calf. This one's seen better days. Actually, it hasn't seen any days. It is a stillborn calf can you give me a morphologic diagnosis or just name the condition? Okay, this is one of those fetal monsters that everybody should know the name of. It's very characteristic. It is seen over and over, this particular defect. And what happens is you have a combination of defects. You have spinal abnormality with severe kyphosis and lordosis and scoliosis. And what happens is the entire body is bent backwards and twisted, and then the back legs are often, this one's a little odd, often they show up over the head, but you have significant spinal abnormalities. And you also have a large rent in the abdomen with eventration of all the viscera. So it's a bent up calf with eventration, and this particular condition is known as schistosomus retroflexus. And you look at it and say, wow, that can't happen too often. I'm not saying it happens often, but they usually always look like this. So there are a number of fetal monsters that you should know the name of. And then when you take a good look at these animals, when you have one congenital abnormality, you usually have a range. So this is the one you want to go in. You want to take a good look at the rest of the skeleton, especially craniofacial, because they often have some abnormalities there. And then start counting things like, does it have both kidneys? Look at the palate. Do a complete autopsy on these, just like it was a normal stillborn, and I bet you're going to find a couple of other things going on. Slide number 3 is a great example of how I really don't like the green background. Okay, it's tissue from a chicken. Can you give me a morphologic diagnosis and describe the histologic lesion? Okay, time's up. Here's your control. Your control is on the right. This is pretty normal. This is the tibia. We're looking at a fairly normal growth plate from a growing animal. And then over here, this one is markedly thickened. The name of the condition is tibial dyschondroplasia. The histologic lesion, which you could probably turn into a nice morph, is a failure of maturation of the hypertrophic zone of the cartilage. That's where the chondrocytes become big and hyperplastic, and that's the stage right before they degenerate. Then you have ingrowth of vessels into the large columns in between and mineralization. So what happens is that never happens, and you get this large hypertrophic zone. And you can see this sometimes if you're eating drumsticks. It's always fun to, if you've got nothing better to do and you have a knife on you, sort of carve into it. And maybe you'll get lucky and you'll find something like this. It's not that abnormal. And pretty much everything has been thrown at. This is a result of everything from abnormal rations to the presence of fusarium toxin in the, I don't know exactly what the cause is. It probably is largely a genetic issue. I'm sure that there's a gene in there that has been switched on or not been switched on that causes this. But the name of the condition is tibial chondroplasia, and it's a retention of the hypertrophic cartilage and lack of mineralization. We used to call for morphologic diagnosis, we used to pretty much call everything osteochondrodysplasia. That was back in the 80s and 90s when I took the exam, and you could sort of get away with that back then. Everything was chondrodysplasia or osteochondrodysplasia. Okay, and then the test got a little more sophisticated, and then we would say for a while, oh, it's chondrodysplasia with retention of cartilage cores. And that worked for a couple of years. But now I think that in your morphologic diagnosis, you need to know a little bit more about the histologic lesion. So for this, for full credit, I would want you to say, among all the other big fancy words, with retention or expansion of the hypertrophic zone of the growth plate. Without that in your morphologic diagnosis, I don't think I would be able to give you full credit for this. So it's a great lesion. And don't just write osteochondrodysplasia and think you're going to get away with that. This is tissue from an ox. How about a morphologic diagnosis and name the condition? Okay, you can get a little bit confused on this, but what we're looking at is we are looking at the markedly thickened pericardium and epicardium. This is the heart, believe it or not. And the morphologic diagnosis is a diffuse, chronic, suppurative pericarditis and epicarditis. Name of the condition is traumatic reticulopericarditis. Let's use our doctor words. A lot of people call this hardware disease, but that's not really a doctor term. So traumatic reticulopericarditis. Okay, there's two ways that you get the products of fibrin and suppuration within the epicardial sac. One is a systemic bacteremia, and it ends up in there. We see that a lot. It's usually a lot more fibrin, a lot less pus. And so if you see fibrin in the pericardial sac, I want you first to think about septicemia, because we see that a lot. The pericardial space is potential space, so a lot of bacteria like streptococcus, the gram-negatives, can cause fibrin to accumulate, but there's not a lot of pus. When you see pus in the pericardial sac, it's usually due to traumatic implantation. And the reason it's called traumatic reticulopericarditis is that if cattle who are not the most discriminate eaters, they eat a lot of stuff that they probably shouldn't, and they may get little pieces of wire because it used to be, and it's not as common anymore, but when the hay would be chopped up and fed to the animals, but there was wire in the hay, and this wire would get chopped up as well, and it would get chopped up into these very small pieces, about 3 or 4 inches long, and then the animal eats them, and they end up going through the rumen and ending up in the wall of the reticulum. Sometimes they go sideways, through the ridges in the reticulum, and it's no problem. But sometimes, due to muscular contraction, they go outwards. They go outwards through the reticulum, and if they point north, they can go through the diaphragm and puncture the pericardium. They would be on the ventral side of the animal, and they would just go north through the diaphragm. And the big problem is when some of these pieces of wire were bent. They're bent in the shape of an L. If they were normal, they were not bent. Sometimes it would just push it through and end up in the thoracic cavity, even in the pericardium, and then that wound would wall off. You'd have a very localized infection. What's happened in this particular case is one of those that's bent, and the long part has punctured the diaphragm, gone into the reticulum, and it's gotten caught by the little hook at the end, and that stays in the reticulum. Okay, that ends up wicking bacteria and fungi and protozoans and filling up the pericardial sac. This, if you've ever seen one in person, you open it up and it stinks to high heaven. It's all those digestive bacteria in the pericardium. The fibrin that is deposited as the heart beats, it tends to stick the pericardium to epicardium and to pull it back again. I'm not a food pathologist, don't like to use those terms, but people call this the bread and butter heart. If you look at the ceiling and a lot of including the ceiling of this particular room I'm in, you have this patterning that they do to keep it from being smooth. And it's sort of a similar thing. Two things that stick together and then pull apart, stick together and pull apart. So you get this, as they say, bread and butter heart. Traumatic reticuloperitonitis, chronic suppurative and fibrinous epicarditis. Look how thick the epicardium is, no longer translucent, and pericarditis. This animal can be so affected that it will go into heart failure, starting in right heart failure. And this is one of the causes of right heart failure. Yesterday, I think we looked at brisket disease. There's another cause of right heart failure. When there is so much exudate, the heart just cannot expand enough to empty the right heart. And so you get blood backed up into the ventrum of the animal. Okay, slide number 5 is tissue from a cat. Can you give me morphologic diagnosis and a likely cause? Okay, time's up. This is a tongue from a cat. No secret there. We are looking at multiple intact vesicles on the lateral edge of the tongue. There might be some on the other side. It's a little bit cut off. This is beautiful. Somebody got this at the exact right time before these popped. Okay, there are a couple of things that can cause these vesicles, but the one that you probably need to put at the top of your list is feline Khaleesi virus. Okay, what happens is that you get to a few cells are infected, and then you have centripetal spread of the virus. It forms a vesicle, and then eventually these cells die, the vesicle breaks, it becomes an ulcer. So in a little bit more long-standing cases, you can see extensive ulceration of the tongue, of the oral cavity with Khaleesi virus. Now, Khaleesi virus is extremely common in shelters. When it gets into a shelter, about 100% of cats have it. They have antibodies, and they can asymptomatically be shedding this at just about any time. Now, it's never been a real problem until the last couple of years, but the animals will get this ulceration. They will get a minor respiratory infection, usually upper respiratory infection, and Khaleesi virus is usually in the mix with shelter cats with snotty noses. Viral rhinotracheitis caused by herpes virus would be the top, and that would be a very that would be probably my second guess for these ulcers, because herpes viruses, they tend to cause some oral lesions, and you can see this, but certainly I want to go with Khaleesi virus on this. Upper respiratory infection, or a component of upper respiratory infection, a little bit of lower respiratory infection in young animals and kittens. It can cause an interstitial pneumonia, but it usually doesn't cause a lot of problems. About 10 or 15 years ago, there have been a number of outbreaks, especially on the West Coast, first detailed by Dr. Patty Pesavento, fantastic pathologist dealing with shelter diseases on the West Coast, and she noticed that these animals were developing Khaleesi virus, but they had much more significant signs. They had significant mortality, which got up to 60% in some cases, and these lesions, it was much more than these blisters and a little snotty nose. These animals were developing a significant edema of the haired skin and necrosis, and also there was significant damage to the pancreas, and the mortality was very high. And it appeared to be local outbreaks, and so the thought is that this virus will mutate. There have been 3 or 4 of these outbreaks. That's one of these things that you want to think about when you see cutaneous necrosis, especially in a shelter setting. Can you be dealing with this the new highly pathogenic, mutagenic Khaleesi virus? So, but this is old-time Khaleesi virus vesicles on the tongue. Slide number 6 is tissue from a dog. Can you give me a morphologic diagnosis and a cause? Okay, it's an absolutely fantastic picture we are looking at the top of the larynx, epiglottis here, and here is the cricothyroid cartilage, and you can see the musculature on the top, the cricoretinoideus muscles. On one side, they look pretty good and robust and red. On this side, it looks much thinner. It is white, does not have this robust look. There are streaks of fibrosis, so there is cricoretinoideus atrophy. This is focally extensive unilateral cricoretinoideus atrophy, or atrophy of the cricoretinoideus muscle. Now, the dorsal and the lateral, the dorsal is very small. This is largely the belly. The lateral cricoretinoideus muscles pull the aretinoideus cartilage out of the way. We can't see it. It sits down in here, and they pull it out of the way. If there is damage to the recurrent laryngeal nerve by a variety of causes, that is what causes or results in innervation. Remember, if you damage the nerve, it goes to a muscle, that muscle is going to atrophy away, and that's exactly what has happened here. So damage to the recurrent laryngeal nerve. It often happens on the left side because, and this hasn't all worked out, the theory is that this is a longer nerve because it loops around the base of the heart, and so that makes it more likely to be traumatized. Now, how is this traumatized? Well, you can see this injury with animals that have their neck stretched and compressed. So animals that are on a choke collar and you pull real hard, especially if they're aggressive, and you pull them up off the ground. It used to be done with some, back in the day, with some very aggressive attack dogs or military working dogs. The only way you could keep them from attacking was to sort of choke them out. Certainly not acceptable today, but we did see that injury. You could see the injury in animals that had gotten their leash caught up over the fence and dangled for a while. It is not the only thing that can cause this particular lesion. This can be a congenital lesion in certain breeds like Bouvier de Flanders. Usually that's a bilateral thing, and it's a degeneration of the nerve, but you can see that these animals, they have a little bit of trouble breathing. They don't bark correctly because those retinoideus cartilages are partially obstructing the airways. This has also been associated with some forms of polymyositis, where it's not a nerve thing, but it is damage to that particular nerve as a result of the syndrome of polymyositis, which affects skeletal muscle somewhat randomly. Most of the cases have been somewhat random, often affects the esophagus. But so there are a number of possibilities here, either affecting the muscle or affecting that recurrent laryngeal nerve. This is a disease that's also seen in horses as well, especially draft horses. They have that big yoke around their neck that they're pulling against, and it's thought that maybe it causes some compression. So morphologic diagnosis, atrophy of the cricoretinoideus muscle, in this case unilateral, and then the cause would be damage to the recurrent laryngeal nerve. These animals are called roarers because of the noise they make due to their stertorous breathing. Tissue from an ox. Tissue from an ox, can you give me 2 morphologic diagnoses and 2 causes? Okay, time's up. What a wonderful, wonderful picture. And whenever you see a larynx and trachea that is as hyperemic and red as this, you are dealing with a diffuse fibrinonecrotic tracheitis, and the cause is bovine herpes virus type 1 or IBR. IBR is one of those things, infectious bovine rhinotracheitis, and that's a pretty good description. This is a herpes viral disease. It causes classic alpha herpes viral lesions. So if you catch it early, you may see necrosis, and in that exudate, you may find large viral syncytial cells with beautiful herpes virus inclusions. Okay, this is a condition that primarily affects the caudal parts of the sinuses, that's the rhino part, and the larynx and trachea, and that's it. It really doesn't go down into the lungs. It stops at the bronchi, but this hyperemia is absolutely classic for a gross lesion of this. Remember, as a herpes virus, this is a virus that an animal can contract and cause no problems until you have recrudescence during times of stress. Maybe it's in the feline or something like that. And obviously, if you've ever had a bad tracheitis, you're coughing, you're coughing, you're coughing. And so we have a second lesion here in the larynx. And we have a focally extensive area of necrosis. And this is what happens when an animal's coughing and coughing and coughing. And these parts, every time it expels air with significant force, these parts of the dorsum of the larynx rub against each other. And you get this little area of ulceration. It's probably bilateral, but this trachea has been bisected, so we're not seeing it as a bilateral lesion. But we have a focally extensive, a deep area of laryngeal necrosis, or you could say focal necrotizing laryngitis. That would be fine. And the cause of this lesion is by far going to be Fusobacterium necrophorum. Fusobacterium necrophorum is a common inhabitant of the nasal cavity, respiratory tree, and the GI tract of cattle. And it's always there. When you get ulceration, it is not an uncommon opportunistic invader. In the mouth, we call it necro. Here it's called necrotic laryngitis, and that's probably going to be Fusobacterium necrophorum. Another possibility in this particular lesion would be Histophilus somni, another bacterium that is pretty common in feedlot situations, and some animals may be naive, they may have a concomitant infection, and it is one that also likes to colonize that particular area of ulceration. So top of the pops is going to be Fusobacterium necrophorum, but I'll take Histophilus somni. So great twofer, fantastic lesion overall. Well, we're doing a lot of cattle. We're doing a lot of respiratory. This is not an ox. This is a horse. Can you give me a morphologic diagnosis? Okay, epiglottis again. We're in the larynx. We are probably in the pharynx as well, maybe the distal pharynx. And we have all of these nodules here. We have some here. There's sort of a nodular proliferation on the epiglottis back here in the larynx as well. This is multifocal coalescing laryngeal pharyngitis and laryngitis. And this is a very common non-specific finding, especially in animals that have had some chronic respiratory disease. It may be they had a subclinical case of equine herpes virus type 1, or maybe they are a roarer. I don't see that here, but we don't get to see the whole thing. But you have this, and this, if you sample it, you will see just a lot of lymphoid tissue. So lymphofollicular pharyngitis and laryngitis. Any animal that has problems in its airway or stertorous breathing or rough breathing is probably going to develop this. This may contribute to it, but it is not specific for any one thing. So let's remember that. And this is an incidental finding, but one that suggests we need to look harder at the respiratory tract here to see what's causing this change. We have 2 more slides for today. And this is from a red fox. Can you give me a morphologic diagnosis and a cause? We've let a lot of these red foxes here in this part of the country. Here in Maryland, and not uncommonly, you'll see them running across the road, especially as it starts to get dark or early in the morning. And quite a few of them have these patches of hyperkeratosis and alopecia. Sometimes it's very sad because it covers the body, but here's one on the leg, and this is a focally extensive hyperkeratotic dermatitis. I find hyperkeratosis, when I'm looking at gross lesions, is probably my most commonly used descriptor, because the skin doesn't have a lot of options. It can ulcerate, it can form cysts or whatever, but hyperkeratosis is a result from chronic irritation, and the cause here is Sarcoptes scabiei. This is sort of the scourge of red foxes in this area, and I used to see them, and I used to put out food for them with some ivermectin in them, and hopefully it would help them. So this is a focally extensive hyperkeratotic dermatitis. Sarcoptes scabiei, all the sarcoptid mites, like Sauroptes, and they live within the epidermis. The epidermis becomes very acanthotic, and you have tremendous hyperkeratosis, a very thick keratin layer, and that's where these mites live. All the stages are in there. The adult males, the females, which are the biggest, they lay their eggs in tunnels in this hyperkeratotic skin. The nymphs will live in there. They're spread by from animal to animal by direct contact, and it's very common in wild animals, especially foxes, but well over 350 different species of mammals have been identified as having Sarcoptes scabiei mites. Some to the extent like pigs, where they have their own variant, Sarcoptes scabiei variant suis. I don't know if that's any different than anyone else, because But it used to be such a big problem in pigs. We don't see that much anymore due to current practice of raising pigs. But if the pigs are just raised outdoor in a pen, yes, you can see sarcoptes. Sarcoptes scabiei in dogs and cats, very well known. And people can get sarcoptes from, it can be a zoonotic disease. And you get this red, itchy rash. The good thing about sarcoptes when we get it from domestic species or working with wildlife is that it does not complete its life cycle. So you don't get a long-standing reaction. The adults will burrow into the skin, but they will not reproduce. They will die. You'll still get that itchy inflammatory reaction, but you don't have to worry about this growing, spreading, active infection. Okay, let's go back to an ox for our last slide. Can you give me a morphologic diagnosis and a cause? Okay, time's up. We have these very large, thick-walled white cysts within the liver. These are hydatid cysts. So I would call this multiple hydatid cysts. And boy, there are a lot in this small piece of liver. The cause is Echinococcus granulosus. This is a cystode. This is an intermediate form of the cystode. The animal has, in some way, form, or fashion, has ingested dog poop. Okay, the adults are dogs. They're very small tapeworms which live in the intestine of dogs and other wild canids. And they will reproduce sexually in the dog. They'll shed the eggs, and then the eggs are infective, and the animal gets into the eggs. They hatch out. The hexacanth embryo will burrow through the wall of the gut and get into the portal system, where it gets into the bloodstream, and they go primarily to the liver. And if they don't get stuck in the liver and grow there, they will go into the bloodstream. They will go through the heart, and then they usually get stuck in the small capillaries of the lungs, which they will proliferate. Realizing that this is a blood-borne parasite, you can have a hydatid cyst anywhere. They've been known to be in the brain of animals, where they cause a lot of disease, but not so much in the liver. A couple things about hydatid cysts. We look at these, they have very, very thick walls, part of which is produced by the developing cestodes, part of which is walled off by fibrous connective tissue. But this is very thick. And I like to say that you can get these in camels. You see them in all sorts of herbivores. Anything that picks these up, that eats some of these eggs, even people can get them. They're very common in certain rodent species like voles, but you can see them in herbivores because they're grazing grass that maybe this dog has, or fox or coyote has pooped on, and so they get these cysts. The wall of the cyst is so thick that you can have it in a camel liver in the Sahara Desert, and that camel dies for one reason or another, not because of this, and then it sits in the hot Sahara sun at 130 degrees for 2 weeks. When you get there, there's nothing left except a big flat sort of desiccated camel, except you will find these cysts because they are so hardy. The other thing about the inside is, if you look, it looks like there's little white sand in here. And these are protoscolices. And all of these little white dots, which are referred to as hydatid sand, will develop into an individual tapeworm. They are protoscolices. They're the developing part of it. So when the animal dies and a canid gets into this liver and starts eating this, it will get a nice big dose of tapeworms if this is still viable, if it's not long degenerate and mineralized. So it's going to get a bunch of tapeworms, and then the life cycle will continue. So hydatid cysts, look for them in the liver, look for them in the lungs, realize they could be in any organ of the body, but a great lesion. And that brings us to the end of Gross Patch Challenge number 60. I hope you have enjoyed these little stories as much as I have enjoyed telling them. And with that, I will leave you to your Sunday. And I am going to, I don't know, I'm going to try and get some work done and put together some tests for my residents. And there's always something to do pathology related around Casa de Williams. So with that, have a great day. Stay safe. Be careful. And I hope to see you all tomorrow.